Good afternoon, everybody. Today I'll be talking about our Indian experience with insulin pump therapy. Continuous subcutaneous insulin infusion via an insulin pump is the most physiological method of insulin delivery that is currently available. And this has been endorsed by all the major pediatric endocrine societies as well as the adult diabetes societies worldwide. A consensus statement by the American Association of Clinical Endocrinology says that the ideal candidate for a continuous subcutaneous insulin infusion via an insulin pump is a patient with type 1 diabetes or insulin dependent type 2 diabetes, currently on MDI, monitoring regularly, motivated to achieve good control, willing and able to carry out the tasks required for this therapy, and a patient who is willing to maintain frequent contact with the healthcare team. Now, coming to the benefits of insulin therapy, I think you are all familiar with the benefits, and we know that it can result in tighter control due to the improved glycemic control and a decrease in the glycemic variability. The multiple basal rates result in improved control of dawn phenomenon and the exercise management. There is better protection from due to the decreased severity and frequency of hypoglycemia, as well as a reduced risk of long-term complications. The quality of life improves too for most of these patients with one insertion every 3 days, and this results in 90% fewer injections. There is also more flexibility in their lifestyle because they have a sense of well-being. They can eat whatever they want most of the time whenever they want, and also that they can carry their insulin is with them all the time wherever they go, so it gives them a lot of convenience too. And better control results in reduced risk of complications. As you can see, as the HbA1c increases, the risk of long-term complications of diabetes increases. So good control is very important for all our patients. Now, this is a huge study of the long-term outcome of insulin pump therapy in children with type 1 diabetes from Princess Margaret Hospital, Australia. In this study, they compared children on insulin pump with those on insulin shots. 345 pump patients with matched non-pump controls were followed up for a period of 3.5 to 7 years, and these groups were matched in terms of age and their HbA1c. And so what did this study show? It showed a lowering of the HbA1c. There was a 0.6% lower mean difference in the HbA1c at 7 years of follow-up in this study. And as you can see, they started with 345 patients here, and there were 25 patients at the end of the study. They found that the rate of severe hypoglycemia and DKA hospitalizations was reduced in the pump cohort compared to the non-pump cohort in this study. And they concluded that this is the largest population and the longest follow-up period comparing insulin pump therapy to MBI amongst children and adolescents. And the evidence supports that pump therapy improves and sustains glycemic outcome, reduces the rates of severe hypoglycemia, DKA hospitalizations, and insulin requirement, and it doesn't worsen the BMI in type 1 diabetes patients. So there was another large study from Europe which was published a few years ago, in which they actually compared a huge population of almost 20,000 children under 20 years of age, and they compared those who were receiving MDI with those who were receiving pump therapy. There were almost 10,000 patients in each group, and they were well matched for their age, the sex distribution, duration of diabetes, their BMI and HbA1c. And in this study, they found a marked reduction in the incidence of severe hypoglycemia, with the episodes being much lower in those who were on insulin pump therapy. And the ones who were on pump therapy also had a reduction in the incidence of diabetic ketoacidosis. again suggesting that the risk of complications is probably lower in children who are on insulin pump therapy. So coming to our experience of insulin pump therapy in Indian children, insulin pumps have been available in India since 2003. So that it means that they have been available for 17 years. There are a number of pumps which are available. Most of the models are available from Medtronic in our country. Ipsomed has recently come with an insulin pump to India. And another pump which is used frequently is the Omnipod by some of the patients. This is not available in India, but for those who travel overseas and are able to get their supplies, they are using it. And this is a small pump, as you can see, which is tubeless, and it's a disposable pump which is changed every few days. Now, according to data from the IDF in 2019, the number of incident cases of children less than 14 years was about 16,000 in India, the topmost country worldwide. And they also found that the number of children and adolescents under 14 years of age in our country at that time was almost 96,000. So if we actually take the number of children under 18 years, it would be close to 100,000 children. But currently, what is the use of insulin pumps in our India? In India, currently 5,500 diabetic patients are receiving CSI via insulin pump, of which 65% are type 1 diabetics and 35% are type 2 diabetics. Of these, the patients below 18 years of age are 2,885. So we have only 3% of the pediatric population on insulin pump therapy, which is fairly low. And as you can see in this chart, that most of these patients are in the major cities of the country. Now, why do we have this situation in our country? What are the problems which are unique to our country? I think first and foremost, the availability of specialists and trained personnel is a problem in our country. Most of the specialists are in the major cities and the metros, and the smaller towns don't have specialists. And that is one of the reasons. Cost issues are there. The cost is not covered by medical insurance. Now, I think the army and Delhi government is providing free insulin pumps to patients with type 1 diabetes. So things are getting a little better, but we are far from matching what the Western countries or developed countries have to offer for their patients. Along with this, we do have social and cultural issues. Patients are really bothered over here about having something constantly attached to their body, which I'm sure people in other parts of the world also feel the same way, but it's more so over here. And especially because they don't want the family and friends to know that their child has diabetes. So that is one of the major issues. They don't want to come out with the disease, and they're worried that somebody will notice that the child has something, is carrying something with him, or notice something different. So that really bothers them. And even if they're getting it free of cost, they're not interested in using the insulin pump. There is also a concern about infection, since the hygiene is poor here and there is so much dirt and pollution, as we know. So rightly so, patients are concerned about that. Another problem is the concern about effect of heat on insulin, since India is a warm country by and large, and summers are really prolonged, and the temperature is not well controlled even in our houses and schools. Central air conditioning is very uncommon over here. You usually find it in few offices by and large. And that's why there is a major concern about the insulin getting denatured due to the heat. And another issue is, I think, the limited use. Whenever a diabetic gets onto a group with other diabetics, they will hardly see anybody using a pump. So that's not a positive message which they get. So I think all these problems together contribute to the low usage of insulin pump in our country. Now, coming to our personal experience at our center, Sir Gangaram Hospital, with insulin pumps in children with type 1 diabetes, we have a total number of 72 patients on insulin pumps currently, of which 3 are using the Omnipod. So we thought of looking at our data also after seeing all these studies that were published. So we did a comparative analysis amongst the Indian children with type 1 diabetes who were on insulin pump therapy with those who were on multiple daily insulin injections. Our aim was to compare children and young adults from the age of 1 to 25 years with type 1 diabetes who were receiving insulin via insulin pumps with those who were on multiple dose insulin injections. And we looked at their glycemic control, the HbA1c, the incidence of hypoglycemia and diabetic ketoacidosis, the effect on the BMI. Now the age group here is up to 25 years because this is a 7-year follow-up. So a lot of children, of course, became adults and reached that age while they were on insulin pump therapy and were following up with us. This is a retrospective case control study, and we had two groups, the insulin pump group and the MDI group, which was receiving mostly three shots of short-acting insulin and a basal insulin. Now coming to the demographics of our patients, we had 55 patients in the pump cohort and 64 in the MDI cohort. The age at diagnosis and pump start were all matched, as you can see in both the groups. The duration of diabetes was very similar, so that the remission phase was excluded. The length of follow-up with us was similar in both the groups. The distribution of girls and boys was similar. And the HbA1c prior to the onset of study was similar in both the groups. So they were equally averagely controlled, if I may say so. They didn't have great control, but not terrible control either. But when we compared this group in terms of the hypoglycemic episodes and the DKA hospitalizations, we found that the pump cohort had a higher number of hypoglycemic episodes compared to the MDI cohort, as well as a higher number of episodes of DKA. And maybe because they were getting frequent hypoglycemia and DKA, they were more motivated to get onto insulin pump therapy. Also, the BMI in the pump group, the average BMI was higher in the pump group compared to the MDI group. We should have done Z scores over here, but we were unable to do so. But now we are looking at the Z score data too in these patients. So in these 55 patients who were included in the study, we matched both the groups for the HbA1c at the onset of pump therapy, as I mentioned, and this was within 1.5%. And none of the candidates were using CGMS regularly, because when we did this study, we didn't have too many options for CGMS and not too many cost-effective options. So some of them may have used a CGMS for a short time, once or twice in a year, but nothing more than that. Now, prior to the pump initiation, we took the HbA1c of these patients within 3 months prior to including them in the study. We took their height and weight within 3 months and episodes of severe hypoglycemia and DKA in the year before. Once they were included in the study, and after pump initiation in the pump group, HbA1c was matched at 6 months, 1 year, and after that we took the average HbA1c of every subsequent year. The height and weight were taken after 1 year and every subsequent year, and episodes of severe hypoglycemia and DKA were included in the study for all subsequent years. Now, if you look at the data over here, at the beginning of the study, you can see the HbA1c in both the groups was very similar. The blue line is the pump group and the pink line is the MDI group. Now, in the pump group, initially there was a huge drop in the HbA1c in the first 6 months, which was amazing. And then after that, there was a rise in the HbA1c at 2 years. And after 2 years, you can see again the HbA1c is improved. And overall, throughout the study, if you see, the HbA1c was lower in the pump group compared to the MDI group. The MDI group had similar HbA1cs over a period of 7 years, as you can see in this study. if we see the p values, you can see that there was a rapid drop and then a rise in the HbA1c, but still the drop in the HbA1c was statistically significant throughout the study. And the difference between the MDI group and the pump group was also statistically significant. And we found that the mean difference of HbA1c between the pump and the MDI group over 7 years was about 0.66%. And we all know that even a drop of 1% in the HbA1c relates to a reduction in the microvascular complications to the tune of almost 20 to 40%. And as I had shown earlier, that the drop was most in the first 6 months, and then even through the entire study, the difference between the two groups was significant. Now, what is interesting is that the maximum impact of the HB improvement in the HbA1c was in the 11 to 15 year age group, which was very surprising actually, because these are adolescents and good control at this age is very difficult to achieve. But as you can see, these children did quite well, and they did better than the control MDI group over here. And you can see that the A1Cs had gone up quite a bit at one point of time in the MDI group. So at 6 months, we found a difference of 1.5%. And even at the end of 4 years, the difference was 1.62%, which is pretty good. Now, coming to the episodes of severe hypoglycemia and DKA in both the groups, we found that there was a reduction in the episodes of severe hypoglycemia in the pump cohort, as well as a reduction in the DKA hospitalization episodes. But we found a similar change in the MDI cohort also. So the incidence of both hypoglycemia and DKA improved during the study period, but the difference between the pump and the MDI group was not significant, as we have seen in other studies. And the reason for that may be that even though the MDI group was on injections, but they were following up with us regularly, and they were getting they were taking good care, and maybe that's why there is no significant difference in these episodes of hypoglycemia and DKA. Now, coming to the effect of pump therapy on BMI, like I said, that we are looking at the Z scores now, but at that, when we did the study, we just took the average BMI for both the age match groups. And we found that the BMI was higher for the pump group compared with the MDI even prior to pump initiation. And once we included them in the study, we found that there was an increase in BMI over baseline at 1 year in the pump group by 1.11, and it was 0.46 in the MDI group. And this increase in the BMI over baseline was most significant in the 6 to 15 years age group in the pump cohort. So basically, we had a group with a higher BMI, which was on insulin pump therapy. And I wonder if that was to do with their fondness for food or just a matter of chance, because a lot of children went on to insulin pump therapy just to improve their lifestyle and to be able to eat at their convenience. So that could explain some part of this data. Now, coming to the comparison of BMI after initiation of pump therapy, you can see over here, our baseline was 18.5 for the pump cohort and 16.7 for the MDI. And you can see over 7 years, the difference was almost maintained, and the pump group had a higher BMI throughout the study. So our conclusion of the study was that there was an improvement in the HbA1c at 1 year, which was about 0.7%, and an overall reduction in HbA1c of 0.66%, as I had mentioned earlier. There was a reduction in the episodes of DKA as well as hypoglycemic episodes. BMI was marginally higher. We don't have a p-value, and we're looking at this data more carefully. And our results were actually not different from the developed countries. Like I had shown you 2 major studies, and our results were fairly similar, although our number of patients is much smaller than the numbers in those studies. The other population-specific observations that we found were that the benefits were that the patient satisfaction was excellent. Most of the patients were very happy with the insulin pump and did not want to go back to MDI. They felt their quality of life was better. We had given them a questionnaire regarding quality of life. The fluctuation in the blood glucose levels was less. And the other point that I would like to make was about carbohydrate counting. This was followed by most of the patients. Now, the initial group of patients who we put on insulin pump did not do carbohydrate counting because we were not familiar with the concept of carbohydrate counting. I'm talking about somewhere in 2004, 2005, and we didn't have too much information about the Indian foods either. But then as time went by and carb counting became more popular, more and more patients started using carb counting, and we taught all our patients how to do carb counting. And I would say about 90 to 95% are doing carb counting for their dosing. Now, what were the challenges after insulin pump therapy was started? First was the poor record keeping. They stopped noting down the readings, how much bolus were they taking. They would just walk into the clinic with no record whatsoever, and then we would keep looking at their glucometers and pumps because they felt rather happy and they felt they didn't need to do all this anymore. Local infections were not common. Only one patient had an infection, but he was out of, not in our area, and somebody else saw it. So I'm not sure what exactly had happened. It was an infection at the cannula site. The insulin pump was discontinued permanently by two patients. One patient had taken a short break, but two discontinued it permanently, and they have not gone back onto the pump, and they're happy with MDI out of this group, out of 72 patients actually. Now, the problem of insulin getting denatured by the heat was an occasional complaint too. And what we figured out was that if they did not put 3 days worth of insulin in their reservoir, and they put just a day's supply, day or two supply in the reservoir and then refilled it, this problem was sorted out. Although it was reasonably uncommon, I would say. Most of the time there was no issue. Now, the pump patch coming off due to sweating was is a common problem because the weather gets very humid over here in Delhi, and if the patch comes off, it means the expenditure goes up because they have to put in a new cannula. So we have overcome that problem to some extent by using deodorant in the area where the patient is going to apply the cannula before applying it, and it does help a little bit. And so that's how we take care of this. Then coming to another problem is a delay in changing patches. That's very common, and this is mostly done to cut down on the cost. So a lot of patients don't change their cannulas every third day. Some change it every fourth day, and some will just wait for the blood glucose to start rising before they change the patch. And they do okay for 3 to 4 days, but yes, the control does become bad if they're using the cannula for too long, and we do educate them that this is not the right thing to do. Then another problem that we still face is fear of bolusing in school, even though it's under the supervision of a teacher or a doctor or nurse, whoever is available in schools. But still parents are scared about lows in school, unfortunately. So a lot of them will not take, at least the younger kids, a lot of them are not given boluses in school. They just increase the rate of basal during their school tiffin hours. So that is another problem that we face in terms of having good control. The other thing is that despite being educated about the different boluses, nutrition, etc., they seldom use the special boluses like the square and dual wave boluses. And the eating pattern is not very good with most of the pump users. Despite being educated about it. And carb counting, like I said, is most of them do try to follow. The younger ones where the parents are in charge, their carb counting is followed religiously, but as they grow older, I think that's too much effort for most of the teenagers. In terms of weight gain, like I said, we don't have very clear-cut data, but definitely in the first visit, we find weight gain, which is probably because They do eat more than usual. They get that sense of freedom in terms of food, and also improved control would be causing some amount of weight gain. Now, follow up with these patients is a problem. We saw that the number of follow-ups are almost halved by 2 years, and the follow-up becomes very irregular, which also happens with MDI patients. We know that, but still I feel it's more irregular with the insulin pump patients, and maybe we need to look at that data too carefully. This is one of the initial patients whom we had started on insulin pump therapy at the age of 4 years, who did pretty well as a child, and now he's of course an adult now. Now, I think for success of any therapy, and especially insulin pump therapy, candidate selection is very important. The patient has to be willing to monitor and record blood glucose, quantify the food intake, follow up regularly, and should be interested in having a healthy life and reducing complications, and has to be educated also. And education has to be, counseling has to be done regularly to reinforce how important that is. It is to have good control, which is of course difficult to achieve in most setups, I would think. So my take home message is that insulin pump therapy is a viable option in our country. The glycemic control improves in motivated patients. Just remember that just starting a patient on insulin pump therapy is not equal to good glycemic control. And they have to be educated, motivated, and one has to keep on reinforcing these things repeatedly. Otherwise they forget the basic things also if they don't meet the doctor often enough, and if they haven't been in trouble. Improved quality of life and better control is there for these patients, definitely, and careful patient selection is the key to success for these patients. Thank you.